guys ready to start?
For those of you who didn't get to play with the scope, we have the scope that they use to practice with, so you don't have to open one in CCT. We'll leave it in the CCT drawer and you can play with it when you're on your trips, okay? Just don't break it. Okay, now, Dr. Silverberg with GI bleeds. Yay!
Awesome. Well, thank you guys for having me. I'm going to talk about GI bleeds today. You guys all know that GI bleeds are my favorite topic in the world. Every single GI bleeder I get dies. It just works out that way. If you're on shift and you can present to 2 attendings, present the GI bleeder to the other patient, the other attending, you'll do much better, I swear. All right, so we're going to go through the causes of GI bleedings with a lot of work on varices, because this is probably the worst one that you can have. We'll talk a little bit about pathophys, how do you make the diagnosis, and then some treatment modalities. So what are the causes of upper GI bleeding? Well, you can start from the most benign, the mallory-Weiss tears, and go all the way down to esophageal varices, which are probably the worst. But there's a lot of different things in there that we can go through and talk about. So mallory-Weiss tears, this is less than 10% of the bleeds we're going to see. They're also the most insignificant bleeds we're going to see. We don't worry about them too much. Usually the classic patient is they were vomiting for whatever reason. They smoked too much pot, they were pregnant, they have vertigo, but whatever it is, they're constantly vomiting, and then they stress their esophagus. They get a little tear in the inside of the intima, and they throw up a little bit of blood. And this is what usually makes people come to the ER. They'll be vomiting, 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 but as soon as they see blood, then they're like, oh my God, I'm gonna die, and I have to come and get checked out. And I understand that. To see blood coming out of the inside of your body is scary, because it's a non-compressible spot. This is like the biggest problem with GI bleeding, right? After working here for 22 years, very few things still scare me in an emergency room. GI bleeding is one, and penetrating trauma to the neck. And it's only because you can't compress the thing that's bleeding, because compression is what makes bleeding stop. So you can't compress the stomach, you can't compress the esophagus. You can't get it to stop bleeding, and they just bleed and bleed and bleed and bleed. So little small tears caused by retching, they usually stop on their own, they don't have that much problems. Your hemoglobin probably won't even drop from them, it's only a tiny bit. So not much to do. Just stop the vomiting and you'll stop the GI bleeding. Right? It's pretty easy to do. Give them GI rest, nice bland diet afterwards so their stomach calms down, and it'll probably just go away. There's not very much to do with mallory-Weiss tears. All right, gastritis, it doesn't penetrate into the muscularis mucosa. Most of them are benign, most. But still, 6% require surgery, 8% mortality. That's still a decent amount of patients with it, so it still causes problems. But we see this almost every day we work. Alcohol is a terrible gastric stressor, right? Alcohol causes erosions and causes all sorts of problems with your stomach, with your esophagus, not to mention your liver, and it leads to longer problems. But on the acute scale, it just irritates your stomach lining and it causes gastritis, right? You can have infections or drugs, which also do it. NSAIDs, very, very brutal on your GI system. They take away the mucus. They don't actually burn it directly. They remove the mucus and they remove the prostaglandins that protect your stomach lining. It's not the actual pill that burns it. So you get it from that too. Just remove the offending trigger and it should get better. If you stop drinking, then your GI lining will get better, theoretically. GI rest, good diet, start eating more healthy. It's kind of easy to say just do this, not all people are capable of it, but this is what's going to help. You have to really tell your patients what's going to make them better and try and get them better. PPIs help on a long scale, like after 24 to 48 hours. H2 blockade much, much, much quicker. So if you see a patient in the ED, you should be giving them PPIs to fix them acutely and an H2 blockade to fix them over the next 2 days so they don't come back and they feel better. And then Maalox, something that'll coat the stomach, make it a little bit more calm down, and it'll take the place of the mucus in there so it's not quite so irritated. But remove the offending agent and they should do much, much better. So what about the GI causes of bleeding from infections? Well, there's a couple that you guys have to memorize. It's on all your in-service tests, it's on the boards. So Salmonella, Shigella, E. coli, and it's the H7O157.1, Campylobacter, Yersinia, and C. diff. And then some add on E. histolytica, and there's new Klebsiella that's also involved that people are saying causes it too. But for the most part, it's going to be like the top 3 or top 4. And then once you start taking antibiotics, then you add in C. diff. These are the ones that you're going to most likely see to cause infectious bleeding. There are some non-bacterial ones you also need to know. Norovirus, when it gets really bad, can cause bleeding too. Usually it's a little bit longer time that you have the diarrhea, have the bleeding. But all you gotta do is hydrate these guys. They do really well, just get them hydrated up. Unfortunately, there's no cure for norovirus, no cure for the viruses, so there's not much you can do about it. You just have to give them supportive care. If they get really low, you can give them blood. But I don't think I've ever seen a case of infectious colitis or infectious diarrhea that was bleeding and required blood. They just stop after a little while, and then they just increase their PO intake of iron through spinach or whatever other iron sources you want to give them, and their hematocrit comes back. It's rare that you have to actually give them blood, but sometimes occasionally you might. And then Cryptosporidia and Cyclospora, those are two other ones that are also rare. We saw them much more like when I was training back in the HIV epidemic days because we didn't have any drugs for it, and they got really, really, really bad GI infections. But now that we have all these medicines for HIV, it's actually much, much better. You very rarely see it that it gets this bad. So fluoroquinolones, 3 to 5 days. If you think it's an infectious cause and it's caused by one of those ones you saw on the list, remember those are all gram-negative organisms, so gram-negative coverage works. If you had antibiotics recently and you think about C. diff, you can send off the test for C. diff, and if it comes back positive, then you may want to do something besides a fluoroquinolone. Then you may want to try metronidazole or PO vancomycin. Remember, vancomycin is not absorbed, it only stays in the GI tract. So the PO works only for C. diff, it doesn't work for any other bug that's inside your body. In children, they have a risk of getting HUS if you give them antibiotics, so they really shouldn't, even if they have bloody diarrhea as children, you really should not give them antibiotics because they'll end up getting sicker. Peptic ulcer disease, this is an erosion of your stomach lining and it goes down to the muscularis level. It could be either in the stomach or duodenum, and it's way, way, way more common in older people. In younger people you see who have belly pain and GI bleeding, it's most likely to be gastritis and involve only the superficial layers. But as you get older, your ability to compensate for NSAIDs or for other stomach irritants goes down. You don't produce enough mucus, you don't produce enough prostaglandins, and you have a much higher chance of eroding deeper into the stomach and getting ulcers. Plus your ability to produce acid is much stronger as an adult than a child, so you have a much higher chance of getting it as an adult for that reason too. Remember, as a kid, you can get botulism from honey, because when you're a child, you don't make enough acid, you don't destroy the spores of botulism. But as an adult, you do. So children can get infantile botulism from not destroying the spores because they don't make enough acid. Drugs like NSAIDs, we use a ton of Motrin, ton of aspirin. These are really bad drugs on the stomach. They stop it from making prostaglandins, and they block your stomach's ability to fight off acid. So once the prostaglandins are not there, you have a risk of getting these ulcers. Right? And then everybody thinks about ZE syndrome. We all talk about it. I've never seen a case of it in my 22 years working, so I don't know how common it is. I don't know, maybe some of the EMIM guys have seen it on the floor, but I've never seen a case of it. And then of course stress. You guys have a little bit of stress in your lives, makes your acid production go up. Stress is one of the things that causes more ulcers than other stuff besides really NSAIDs. So you have to do stress management and try and deal with it. And then H. pylori, almost everybody with ulcers, I would say 90% of people with ulcers are infected with H. pylori. So the big thing you're looking for and you want to make sure you don't miss is perforation. Remember that if you see air under the diaphragms on chest x-ray or on upright abdomen, right, this is a sign that they have perforation. Most of these people will be peritoneal and you'll kind of know it before you even shoot the film, but some of them not so much. Some of them you may miss it. So always look on the right side first, because the right diaphragm is much more likely to show it. It's got the liver right under it, and you'll get a stripe of air between the liver and the diaphragm, and it shows up a little bit better than on the left. Sometimes on the left you can confuse the stomach bubble for free air. So what you do is you look for the edge of the stomach bubble coming down, and it doesn't touch the free wall of the abdomen. If your line comes down, or the diaphragm line comes down, there's two diaphragm lines, then that's more likely to be your stomach bubble. If there's one line and it goes out all the way to the edge of the abdomen, then it's most likely to be free air. Notice too, this person has air inside their pericardium, inside the mediastinum. All right, when you get perforations in the stomach, it's going to go all over. It's going to track upwards, right? Air is very buoyant, so it goes up. It's going to get up through the cruce of the diaphragm around the esophagus, and it's going to go into the mediastinum too. So while you may not see anything under the diaphragms, you may see it in the mediastinum. This is another symbol that they have a perforation. So symptoms, it's usually a burning pain in the middle of the chest, upper stomach, lower abdomen. They may present painlessly. A lot of people will see who just have anemia of 6 or 7 hemoglobin, and then you check them out and you get scoped and they find they have ulcers. right? People with hematosemesis or hematochezia or melena, this is usually a sign of brisker bleeding. If you can get blood to come out of one of the holes in your body, then usually it's before your body digests the blood. It means that there's much, much more blood in there. So we talked about H. pylori already. It's a microaerophilic bacterium, and it's really associated with a lot of the GI bleeding in the world. They say 50% of the world has H. pylori infections, right? It lives in the mucus, and what it does is it splits urea. So this is one of the tests to tell if it's there, right? You give them urea that has carbon-14 in it, and then if they breathe out CO2 that has carbon-14 in it, you know that they have a urea-splitting organism in their gut. So that's one of the tests. You can also do a blood antibody test, a stool test, a urine ELISA test, but the gold standard is still biopsy. All right, you have to take a piece of the stomach lining, put it under a microscope and look at it and see if the H. pylori is there. Still the gold standard. Not all these tests are 100%. So treatment, you want to calm down the acid production in the stomach. You want to coat the stomach. You want to make sure the stomach has got a little bit more protection than it had before. So PPIs and H2 blockade will slow down the acid production. Right? You can give them sucralfate as a coating agent. And then we'll talk about triple therapy in a second, but you want to kill off the H. pylori. If you can get rid of the H. pylori, your chances of having ulcers go down a drastic amount. Smoking too, really bad for ulcers, all right? So if you're a smoker or your patient's a smoker, you have to counsel them on smoking cessation, at least until their GI problems are gone, but really they should stop permanently. And then having a better diet, more healthy diet, a lot of roughage, a lot of vegetables will also help with that. So triple therapy is omeprazole, amoxicillin, and clarithromycin, plus or minus bismuth, Pepto-Bismol. If you're penicillin allergic, then you want to try Metro instead of penicillin. It's a similar coverage, but they still need triple therapy to get rid of it. It's a really hardy organism that is not just killed with simple antibiotics. You have to do triple therapy for it. So some other causes of upper GI bleeding, right? Esophagitis due to GERD, people with a lot of acid production and an incompetent lower esophageal sphincter. The acid comes back into the esophagus and burns it, takes off the lining, and then you bleed from that. The more overweight you are, the more chance you have of your abdominal fat in the mesentery pushing the stomach contents out. So that comes up. So people who have GI bleeding, you might want to counsel them on weight loss. AV malformations in the stomach can bleed a lot. We saw a case a couple of years ago now, probably 5 or 6 years ago now, where they scoped somebody who was bleeding and there was a vessel there. And it was bleeding just a little bit. And the GI guys came in and they tried to inject it, and they injected right next to it, but they must have got the vessel, and it just started spurting blood. And then the whole stomach filled up like a swimming pool, and they were filled with blood. So GI scoping is not always the answer to fix bleeds, but theoretically it should help. But the question is, how acutely do you need it? We'll talk about that a little later in the lecture. And then of course, foreign bodies and trauma, always a problem. If you eat things that are sharp, certain vegetation that you can accidentally ingest, or maybe you ingest certain things on purpose, they can cause scratches on the way down too. So let's talk about foreign bodies and trauma because it's the most entertaining part of the lecture and that's what you guys like. What do you guys see here?
Dentures.
Good, swallowed as bridge, swallowed as dentures, right? We see that actually more often than you think because a lot of elderly people, very deep sleepers, and they don't take their dentures out when they go to sleep, and they fall down the back of their throat and they're gone. This one. Carpet staples. Carpet staples are way longer than regular staples. They used to hold the carpet down to the floor. This guy actually ate them on purpose because he was in prison and wanted to have a trip to the infirmary and not stay in prison. It's much nicer in the hospitals of the prison than it is in the prison itself, so they like to get out and take a little 3-day pass. So until they can pass the object, they get to pass out of the prison. APN laterals as a kid, obviously, right? You guys see the growth plates? It's mom's earring. Mom had the kid on the shoulder. The kid was chewing on the earring and then just swallowed it. Pretty obvious. Straight pin. Straight pins are much worse to ingest than safety pins because obviously safety pins have no points. Pin should not be confused with needle, right? Needles have an eye on the back. So this is a sewing needle, also child. Here, safety pins, much, much better to ingest. If you're going to ingest something, safety pins are better. Safety pins, if I see this on x-ray, they just go home. Sewing needles and regular pins, they have to come out. They're going to cause perforations. Sheet metal screw, not to be confused with wood screw, different head shape.
Rounded versus flat.
So this one probably wasn't ingested, but I thought it was an interesting x-ray anyway. Phillips head screwdriver, the tip is round. 1 in a million chance, Doc. 1 in a million chance. So this is a common prisoner complaint. Do you guys see the foreign body? This is a double-edged straight razor. What they do is they take masking tape and they wrap the blade in masking tape and then they swallow it. So it has no danger to them, but as a doctor seeing it, a razor is really sharp and it's really a big danger, so we keep them in the infirmary for a few days until they pass it. But it's very, very common prison occurrence for them to swallow these things, so you guys need to register what it looks like and make sure you pick them up. What's that one? So it looks like a coin, except it's got a rim around the edge. So that makes it a button battery, which makes it way, way, way more dangerous than a coin. Right? Button batteries in your GI system, they open up, they let out the internal contents, and then they cause burns. Not to mention, just the current going from the top of the battery to the back of the battery can also cause perforations. So anybody with a button battery in their GI system has to come out. Who sees that one? It is not the cholecystitis clips.
Cucumber. Oh, I see it.
So while vegetables are good from one end, they're not very digestible from the other end.
Chew it first.
Has to come out. Well, that's helpful, Adrian. Thank you.
Not if you're a snake. Not if you're a snake.
This was larger of the ones I've seen.
It's like the opposite of a Throckmorton.
Right? This one?
A baseball bat?
That's a little large, right?
Bowls. People have bowls.
Toothbrush. It's got the little bristle at the bottom. Of course, it's still in its travel case. You can see the case around. Some people don't pack well. They don't have enough room. You got to stick it someplace else.
Watch those weight limits. Watch those weight limits.
And then, of course, if you have a regular toothbrush, you also take your electronic toothbrush on vacation with you. Great. Very interesting how it's constructed. You guys see the battery at the top, the engine, and then the spindle, and the toothbrush holder is just a little bit off center on the spindle, and that's what makes it vibrate. Very ingenious device. A little harder to get out, smooth edges. When you go to pull it out, it forms a suction, and it won't come out very easily. So you got to pass a Foley around it to let air in above it, and then you can pull it down. Very important fact about the rectal foreign bodies. This one was in Fast Track probably 3 years ago. It's actually an interesting case. It was a Spanish-speaking gentleman. The doctor who saw the patient was English-speaking only, didn't get a translator, and didn't really understand, but sent the guy home with belly pain. Came back the next day with more belly pain, and then his x-ray was shot by the same person, and they're like, oh, now I understand what he was saying. I put the garden sprinkler in my bug. Obvious one.
A speaker? Oh, it's pretty good.
Right, you can see the little nozzle on top where it goes into the can.
Still looks like a Bose. Electronic toothbrush heads?
Not quite. This guy is a long story, Kings County legend. He was on vacation from California. Normally puts only one vibrator in his butt, but today he put two because he was on vacation. And usually they come out real easy, but this, because the two of them are there, they kept running into each other and bouncing off each other, and they wouldn't come out. Very difficult to get out two. Much more difficult to get out two than one.
One at a time.
All right, so let's switch gears, and we'll talk about the meat of the lecture now. So esophageal varices, right? These are caused by cirrhosis. Most cases of cirrhosis we're going to see either due to alcohol or hepatitis. That's what we see the most of. And what happens is, as your liver gets destroyed, you get portal hypertension. Portal pressures build up, and the blood goes from the portal side into the venous side, right? You guys all know that as you digest protein, you get more and more side effects of the GI bleed. You get somnolent. So what protein do you digest? Well, you can have a lot of food, but you can also have bleeding. And blood has hemoglobin in it. Heme is the metal part, and globin is the protein part. So the globin is a very, very large part of blood. And that's a lot of protein to digest or ingest and then digest. So a lot of people who have history of GI bleeds and get somnolent, you should think about a new GI bleed. That's very, very, very common, right? 60–70% of people who have a single bleed will rebleed. That's a tremendous amount of patients. 30% require surgery, and a third of upper GI bleeds result in death. That's a tremendous number considering how many GI bleeds we see. So cause of cirrhosis hepatitis, because B and C, A, D, and E usually do not cause bad hepatitis, do not cause cirrhosis. But alcohol abuse is a big one we see. We don't see that much schistosomiasis. And of course, Wilson's, hemochromatosis, TB, and Budd-Chiari Syndrome. Those are rare causes here, but they're much more prominent throughout the world. Obviously, we don't see them here almost at all. I don't think I've ever seen a case of Budd-Chiari. I've seen one of these, one Wilson's, and a few schistosomiasis. So you'll see them, just not that often. Budd-Chiari syndrome, this is hepatic vein thrombosis. So when the hepatic vein clots, you have to worry about the portal system, right? In 50% of people, no cause, nobody knows why it happens. But it's really debilitating. It's a horrible, horrible disease, especially in third world countries. Some people say that it's almost uniformly due to protein CNS deficiency, but a lot of people don't get diagnosed with this, so they're not really sure. People with malaria also get it because their blood sort of slows down flow, and you have a higher chance of having clotting too, and you get a very large amount of protein-rich ascites. So whenever you have these patients coming in asking to be drained, you're pulling off all their proteins and they're just losing it out of their body. So you have to synthesize new protein, and they're wasting calories and wasting energy synthesizing new protein. So if the patient doesn't have respiratory problems, you really should not be tapping them. I know people ask you to tap them because it's more comfortable walking around with less weight and they just feel better. But the truth of the matter is it's better for the patient if you don't actually tap them, unless they're having respiratory compromise. If they have respiratory symptoms, that's totally different. But the guys who just come in and say, yeah, my belly's big, can you tap it? They always tap it. You really shouldn't be doing it. You're wasting their calories and you're exposing them to chances of having infection, right? A closed cavity that has no infection, until you put a foreign body in there, it'll have no infection. But tapping joints, tapping bellies, it's not a high risk, but it's still a risk of catching an infection. So what happens when you have cirrhosis? This is the real micro level pathophys, but endothelin 1 causes proliferation of the cells, and then you get more nitric oxide. And once you get the more cells in the liver, then your liver sinusoids start to get smaller, and you have less flow through there. It gets higher and higher pressure. Remember that the flow through an object is directly proportional to the width and the viscosity of the fluid and the length of the portal. So when you get a narrower channel, it's much harder to push the fluid through, so therefore pressures go up. That's what leads to portal hypertension. Once you get injuries in there from the actual alcohol being an injury of the liver, you get collagen deposits. Then you get little vancompression due to regeneration nodules when it comes back, and you just get more and more and more pressure inside your liver cord venules. So portal pressure goes up. Once portal pressure goes over hepatic pressure or regular systemic pressure, that's when you have reversal flow, and that's when you start to get in a lot of trouble. Because now, instead of taking all your stuff you digested and putting it into the liver to be cleaned and processed, it's going out into your circulation. And this is what causes all the problems of cirrhosis. So results, liver architecture is destroyed, and you get obstruction to internal flow. You start to get these collaterals building up that go out to the body, and you have loss of function. So what does your liver do? Well, it makes coagulation proteins. So if you have no coagulation proteins, you become coagulopathic. You bleed much easier, right? You can also get encephalopathy out of it. Some people, people used to believe it's ammonia that causes it, but now they think ammonia is just a marker of it. They don't know what actually causes the encephalopathy, but ammonia is just a marker for it. And you can tell how bad they're going to be and how they're going to do by your child's classification. So this is a view of Netter from where the blood is coming from. So you guys know that the portal system is your mesenteric vein, the greater and lesser mesenteric veins, and they go back portal. But where do they meet the regular circulation? Well, one is in the esophagus, that's where you get your varices. 2 is in the rectum, and 3 is the umbilicus. So these are the places where you're going to see portal flow that's backed up. And you're going to see it as hemorrhoids, varices, and caput medusa. We talk about the child's PUD classification a little bit. Initially it came out in 1964, a long time ago, where they had the scoring system. and then they modified it in 72. They replaced nutritional status with INR because it's easier to figure it out. INR is a set number, while nutritional status is a little bit nebulous, right? So it's just a subjective part. So here's the things that are counted in it. It's billy, albumin, INR, ascites, and encephalopathy. And obviously, as you go outward, it's worse disease. But they used it to predict how people would do. So if you had a 5 to 6, you're considered class A, and you probably do okay. You only had 10% mortality. But once you get into the 7 to 9 range, you start getting a little sicker, 30% mortality, and you're put on the transplant list. Once you get to the 10 to 15 range, that's when you get in a lot of trouble. And usually these guys only have 1 to 3 months to live and 82% mortality. So if you can figure out their score and know how sick they are and know what their chances of living are, you can do, you have just a much better idea of how aggressive you need to be with your treatment. So how do you diagnose varices? Well, they have these cool new pills now, the camera pills, where you swallow the pill and it takes pictures on the way down. And once the camera comes out, then you can download the information on it and look at it. But you can't do it quickly because you got to wait for it to pass your GI system. Although somebody told me, which I haven't seen myself, that there are new ones that connect by Bluetooth, and you can actually get Bluetooth information off the pill while it's still inside you. But I haven't confirmed it. I haven't seen it myself yet, so I'm a little skeptical. I don't believe anything until I see it myself. You can also do colorful Doppler on them and look for blood rates, blood flow rates, right? You do transabdominal or endoscopic. And this is to tell you how big the varices are, how much flow is in them, and how dangerous they are. But you can also see them on CT and MRI. Endoscopy, still the gold standard, obviously. So variceal size is important, and anybody with flow rates over 20 centimeters per second, that's when you start to get in risk of rupture. And these are the people who get a lot of trouble, who can really bleed a lot. Right? Active alcohol intake, if you're still drinking and you have varices, that's a really bad sign. That's a sign that you're going to do worse overall. When you drink, you get these red whale marks on your GI system or on your esophagus. And they look like corduroy. I've actually never seen them. I've seen quite a few GI scopes, but I've never seen these red whale marks. I don't know what they are. I've never seen them myself. Your platelet count to spleen ratio will also be an important determinant of how well you're going to do. And what you do is you use ultrasound to get the max bipolar diameter. And then if it's less than 909, you have a worse prognosis. So that means your platelets are low or your spleen is big, one of the two. Right? That's how you get your ratio. So the worse the number is, the worse prognosis you have. And then you can get your hepatic venous pressure gradient. I'm not even sure how they do that. That's definitely above our abilities. So if you're not bleeding, what I want to do is I want to slow down the flow in your varices. And a good way to slow down flow is to give them beta blockers. That decreases contractility and decreases heart rate. That'll stop the blood coming out of your heart, and it'll lower the pressures in your GI system as well. You may want to give them splanchnic vasoconstrictor, which is somatostatin, but nitrates also work, and then behavioral modification, get them off alcohol. Get them off these problems, off the things that are causing problems to the liver. So if you can do any of these things, you can slow down the rate of flow in the varices and decrease their risk of bleeding, decrease their risk of rupture, and hopefully that'll lead to resolution of the varices. Varices are not static, they're dynamic. So if you can slow down the flow in them, they can actually regenerate, or they can actually go away and they can stop flow. They'll sclerose and go away. Right? No drug has an FDA indication for stopping variceal bleeding, stopping variceal flow. People use them off-label, the beta blockers, but it's not actually FDA approved, so just know this when you're using it. If they're bleeding, that's a whole different story. And this is where you start to get in a lot more trouble, because you can have a lot more complications from the actual bleeding. Right? So you want to take their airway away. If they're bleeding from high in the esophagus or the lower esophageal sphincter is closed, as they bleed, blood's going to come up, go into their mouth, and then either come out or go back down into the lungs. So you want to make sure you protect the lungs from blood because it causes injury. You want to get some IVs in them, start to give them normal saline. Not too much because you don't want to thin out their coagulation factors too much. You want to give them back blood. Right? Tap and cross them for at least 6 units. We had a JAG leader come in this weekend and we initiated the massive transfusion protocol. That guy had 8 units of blood, 4 units of platelets, and 8 units of FFP within probably an hour and a half. Nitroglycerin may lower their pressures. You want to give them FFP and vitamin K to reverse their coagulopathy. Medicines we'll talk about in a second. If they're bleeding really briskly and you can't control it, then you want to call GI in right away to do endoscopy. If they're bleeding only a little bit and they're resuscitatable, then maybe have them get seen the next day by GI. But if they're bleeding briskly, you probably want to have GI come in right away. Balloon tamponade we'll talk about, and these are your Blakemore tubes. And then if they're still going and you can't fix it, they may have to go for surgery and portal pressure reduction. Again, endoscopy doesn't have to be right away unless they're bleeding briskly. Then they should be done right away. But otherwise, you have 12 hours of scope. So somatostatin works pretty well at reducing pressures inside the liver. It causes vasoconstriction in there, so it'll stop the flow to the varices. Usually it only lasts 1 to 3 minutes, so you have to put them on a drip. Octreotide lasts a little bit longer, it's a little more potent. And this is a human-made analog of somatostatin, so a little bit better, and it works a little bit longer, so it works a little bit more effectively for you. Vasopressin also works, but also has a pressor effect, so it has a little bit more help for trying to get their blood pressure up and keeping them healthy. And then telepressin is a new medicine, a new synthetic that works for a very long time, and I don't think we have it here, I've never seen it here, but it's just good for you guys to know about it. So once you do endoscopy, what are you going to do when you're down there? Well, you can do sclerotherapy. What they'll do is they'll do sodium morulate or sodium tetradecyl sulfate, although I've seen them use straight up alcohol too, just like 90% or 100% alcohol. And you inject it into the varices and it just scleroses them down. You can also inject next to them and try and hope that just the pressure of the walls being filled with the solution will also slow the bleeding down. There's a controversy of whether you should be using an epi-containing solution or just simple normal saline. The epi is going to cause vasoconstriction, while just the pressure from the fluid should also decrease the flow. But it's debatable whether it really works or not, if the epi works or not. So a lot of them will just simply inject normal saline to try and get slow down. You can do banding, which I'll talk about a little bit more in a second. I think it's really interesting how banding works and how they deploy it. Less rebleeds than sclerotherapy, so probably a better way to do it. The only problem with banding is you actually take the varice and suck it up into the scope and then put a rubber band over it, and you risk tearing it when you do that. So if the suction is too strong and you rip off a hole in the varice, you can see how they'll do much, much worse. And then you can do variceal obturation with tissue adhesives. I don't think it works all that well, but people have tried it. 5 to 10% fail and will require surgery to control the bleeding. It's really important when they're doing the scope for them to flip the scope around 180 degrees and look right at the top of the stomach, because that's where the varices come off of. They come out of the esophageal gastric junction, the GE junction. So you flip the scope back at itself, and you should be looking at the scope coming through the lower esophageal sphincter, and that's where you're going to see the varices. Here's a big fat balloon that's filled with blood. That's a varice. So to band them, what you do is you just pull them out into the scope and you put rubber bands or plastic clips on them. Right? And hopefully once the clip holds, it'll stop flow through them, they'll just sclerose and then fall off. And you'll have a scar there and it shouldn't be a problem. But if the thing that caused the varice in the first place, the portal hypertension is still there, they're going to reform, they're going to come back. Just the ones that you banded will be gone and new ones will form. So here's how it works. I thought this is actually pretty ingenious because it's really a simple device when you think about it. What happens is you have a tube with suction on it, and you press suction and it pulls the varice into the tube. And now the tip of the tube just bends and kind of opens outward, and it has rubber bands preloaded on it. When it opens outwards, the rubber bands just kind of roll off, and they roll off the scope and they deploy onto the varice. And that's how you just do the banding. So sclerosing therapy again, here's not a great picture of it, but they're injecting next to the varice. The varice is here, and they're injecting next to it, trying to get it to slow down. But you can also put the alcohol or the morulate into the varice itself and try and sclerose it. Doesn't have as good results as banding does, but it's also easier to do because if the varices are not sticking out, it's a little hard to get them banded. Complications, quite a few complications to this. That's why it's a little bit questionable whether it's indicated or not. But a lot of people get chest pain and fever from it, right? When you sclerose them and you're injecting them, you're leading to death of the vessel that the blood is flowing through. So they're going to get an inflammatory response to that, and that's going to lead to fevers and pain. Pleural effusions, Inflammation can cause it, but just bleeding can cause it too. And then you can get strictures if your varices fall off and you get scars there. As the scars shrink, if you do a lot of them, it can lead to esophageal strictures. And then, of course, if they don't take, if the sclerosing doesn't work, or if the banding tears something, you can get bleeding, and then you can even get perforation if you're very, very unlucky or not careful. So balloon tamponade, I don't know how many of you guys have ever even seen the tube. How many of you guys actually put a tube in?
Try.
So it's hard to do. The Blakemore tube is a lot thinner than an NG tube, and it's very hard to get down. I would say that 100% of these patients have to be intubated. There's no way you'll do it otherwise. And what you do is you'll intubate them, and you put 2 fingers into their esophagus. And you'll put the tube down between your fingers, and you'll slowly inch it down with your fingers inside the esophagus. And this way you know exactly where the tube is going, but since the tube is not rigid, it's kind of going to bow side to side in the esophagus. So you have to just keep pushing it down until you think you get it all the way in. It's really, really super important that you don't blow up the balloon until you've shot an x-ray and confirm that the balloon is in the stomach. It's really, really important because the bottom balloon, the stomach balloon that you blow up first, is like the size of a softball. So if you have a person with varices in their esophagus and you blow up a softball in their esophagus, you're going to tear all the varices and the esophagus, and they're obviously going to do much, much, much worse. Now you've killed your patient. So you have to shoot an x-ray before you blow up the first balloon. So again, there's 2 balloons. There's a volume balloon and a pressure balloon. The volume balloon is the one that's in the stomach. It's the big balloon that's shaped like a softball. What you want to do is you want to put a certain volume in. I think it's 300.
Don't for varices, sometimes they don't even do the distal, the volume balloon. They just do the...
So from what I've read, the volume balloon is your first choice. Much more important than the pressure balloon, because the pressure balloon is in the esophagus. It can cause necrosis, and it can cause esophagus rupture. So they always try the stomach balloon first, and what you do is you pull back with tension, and that blocks the blood flow from the stomach into the esophagus, and that slows down variceal bleeding speeds. But from what I've read, that's the one you're supposed to do first and try first. If that fails, then you do direct pressure on the esophagus itself.
Would we try to find a manometer so that we're going to put it in and try to follow it?
So that's actually really a great question, Don. I want everybody to hear it. Where do you find a manometer to measure the pressure in the long balloon? And you have to call respiratory. Respiratory all has manometers. When you guys intubate somebody, respiratory is supposed to come around and check your cuff pressures to make sure they're not too high and causing necrosis in the airway. So respiratory all has manometers. Similar goes if you want to measure NIF on somebody with musculoskeletal weakness. You want to measure their NIF. You ask respiratory to bring down a manometer, and that's how they check it. But respiratory has manometers. So you put down the first balloon, that's this one, and you blow it up. I want to say it's 300, but some tubes maybe 350. But you blow it up to 300, and then what you do is you have to weight it and pull it back. You have a question, Noah?
We were just talking about which balloon and when.
So that's what I'm saying now.
Yeah.
So you blow up the stomach balloon first. Once you shot your x-ray, you pull it back against the GE junction, and then once that's failed, then you blow up the second balloon, which is the long skinny tube that's inside the esophagus. And that's supposed to tamponade the varices from inside. But again, if it's too high, the pressure, even with normal pressure, it still might lead to esophageal rupture and it still causes problems. The Minnesota tube is similar, but it just has a port above the big balloon, so you can suck out any blood that's still coming out. So here's what it looks like. You put the tube in, you make sure you're in the stomach, and then you blow up the gastric balloon. Once it's inflated, you have to pull back on the tube however you want. Right? And there's different ways you can do it. We'll talk about that in a second. After pulling back for a certain amount of time, and I don't think anybody knows what amount of time is the right amount of time, if that fails, then you blow up the esophageal balloon. And that's what causes tension and pressure on the varices. So here's it in action. One of the cases we had where you put the tube in, and then you tie it up to an IV pole, and use the pullback, the spring and the Curlex to give you the force to pull back onto the tube. The other way you can do it is you can just hang 1 liter or 2 liters of saline off the end and just have it go over an IV pole, and the weight of the saline will pull down on it and hold pressure as well. The last one, which we used to have but don't have anymore, is you just tie it to a football helmet that the patient's wearing, but I haven't seen the football helmet in the ER in like many, like probably more than 10 years. I haven't seen it here. Did I explain it? No, do you guys have a question? Kenny?
Do you pull out the NG tube then before you?
So this takes the place of the NG tube.
Okay.
It doesn't go in with an NG tube. I've seen people tie it to an NG tube, but then I don't know how you get it out once you have the NG tube down there with the Blakemore tube.
It creates a little opening too.
It creates an opening for pressure to come out. It's also, if you blow the balloon up, it's a high spot that's going to put pressure on the esophagus in one single spot and risk perforation. So I would not attach it to an NG tube to put it in.
Or like you have an NG tube ready to make it pull that out.
Yeah.
I mean, if you use an NG tube to push you're saying you have an NG tube in place?
Yeah.
Yeah, it does no good to have it in there with the Blakemore tube. It does no good.
Yeah.
I've seen people tape it to the Blakemore tube to an NG tube because the NG tube is more rigid, but then once you put it in, you have no way of separating the two tubes. And if you pull one out, you pull the other one out too. So it just doesn't work though.
Do you ever how many times have you successfully actually implemented the one tube? Because the one time I tried failed, and one time I tried saw someone try to do it and also failed.
I've put in 4 now, and I've gotten them all into place, but the patients still die because the problem is they're coagulopathic, right? They're making no liver functions, they're acidotic because they're peripherally clamped down. So they do bad, not because the tube is in there, but because their protoplasm is bad. This is usually a last-ditch effort when the patient is like bleeding, bleeding, bleeding. If you notice in these pictures, like what does it look like? The bed is filled with blood, there's blood running on the floor. These are like last-ditch, it's just a horrible, horrible mess to get these patients. Dirk?
Deep paralyze them?
So yeah, once they're intubated, paralyze them, because you don't want them moving around.
Yeah.
God forbid they get a hand free and rip something out, they're just gonna pull, the balloon's gonna come through the varices, you're gonna be done.
Where is the waveform?
Last I saw, there's one in the shopping center, in the bottom drawer, in the most back by CT. That's the last I saw.
It's
Still there? That's the last place I saw. Joel?
Yeah, I put in a bunch when I was a resident, I haven't put them in maybe for 40 years. And they're a mess. And like you said, you do the bottom balloon, the gastro first, and pull it. That will take care of bleeding from the stomach.
Hopefully.
To the gastro varices, like you said, exactly. Then if they're still bleeding, you blow up the esophageal portion, like you said. Exactly like you said. Problem is too that you're going to have to intubate them if you put this in.
100%. You can't put it in without intubating them. It's an
you're
extra
already
cost.
going to be paralyzed from the intubation. And then
It's just such a soft tube that you can't get it down without intubating them. It's way softer than an NG tube. It's way harder to get in. And because it's soft and kind of like goes back and forth in the esophagus, you have to make sure you get it all the way down to the stomach. If you blow that balloon up that's this big in their esophagus, you're just going to kill them. Everything's going to rupture, and they're just going to bleed to death right in front of you.
What's the esophageal pressure that we want to knock over?
I don't remember off the top of my head. I have to Google it every time. I haven't put one in probably 5 or 6 years.
Is it like on the...
I want to say it's on the tube,
Yeah.
but not 100%. I would just Google it. It's probably faster. I don't know if these things all come with the instruction card inside, because a lot of times you buy them as a case, and it comes with an instruction card in the case, but not in the individual box. If it's there, great, but if not, just Google it. Is there another question? So, if this fails, and you can convince surgery to put them on the table, there is some utility for surgeons fixing it. They can devascularize it, right? They can take out the lower 5 centimeters of the esophagus and the upper 2/3 of the stomach, because that's where all the varices are. But this is really a last-ditch effort. Sometimes I'll just run a staple gun across it, just to clip off everything that's down there and hope to stop the bleeding, and then I'll worry about feeding later on. These guys are super coagulopathic because they're making no coagulation proteins. Their liver is just shot. That's why they're bleeding so much. So if you can reverse their coagulopathy, that'll help. Remember too, they're going to be really acidotic because they've lost a lot of blood, their volume is low, so you want to reverse that too, because acidosis and coagulopathy go together. And then they go on the transplant list, and hopefully they'll get a transplant before they can bleed to death in front of you. So what can you do invasive radiology-wise? Well, once standard therapy fails, you can try and do percutaneous transhepatic embolization, right, which sometimes works, although it's not great. And then you can also do a TIPS procedure. Transjugular, intrahepatic, portosystemic shunt. So you down the jugular into the IVC, and then you go across into the portal vein and you put a stent in. And hopefully that offsets the pressure in the portal vein to go directly into the IVC and gets it out of the varices. Does it work? I don't know. Rebleeding rates, 10%. I think that's a very, very good estimate. I think it's higher than that. And I also don't remember what duration that was. The rebleeding rates in 1 year versus 5 years versus 10 years versus 20 years. Obviously, as time goes on, that rebleeding rate goes up and probably pretty significant. Interesting.
For the esophageal tube extrude, it's 30 millimeters of mercury.
30? Thank you, Don.
You have this patient to be proud of. Just
Control V.
No, it's not back.
No, I give up. Oh, that works. I guess it didn't matter anyway because that was the last slide. So does anybody have any questions? It's my last dive from last week. Some big tarpon. Yeah. So I think if you get in trouble, the Blakemore tube is a possibility, but I don't think I would count on it working. Call surgery consults early, call GI early, get them to band them. I think get everybody on board, load the boat. Massive transfusion protocol, super, super, super important. Get the blood into them. Because giving them saline to raise their pressure is not going to replace the hemoglobin, and it's not going to replace the factors that they're missing. Jimmy?
I'm sorry if I missed it, just about antibiotic treatment in variceal.
So actually, I didn't put it in. You're totally correct. You should be giving ceftriaxone. It just does, the bacteria go across the lumen of the gut when it's hypoperfused, so it's shown to have better outcomes.
Yeah, I think that's one of the other things that showed mortality.
No, that's totally true.
And then just, I've never put it in Blakemore, but I've learned that having them chilled can help pass them, because it makes it a little more rigid, so if you have them in the fridge, put them.
I actually hadn't heard that before. I can see how it would work. But I think as soon as you put it in and it gets in the esophagus, it's going to be warm. It's probably going to negate the effects, but there's no downside to it.
Correct.
So why not do
I
it?
have no idea.
I think it's a good idea. I would try it because at that point you're going to be behind the 8 ball already. Usually by the time you put the Blakemore in, the whole bed is filled with blood. It's running off onto the floor. Every single needle stick hole you've drawn blood out of is bleeding. They're usually pretty dire straits when you get to that point. All right, remember, present to the other attending. If you get a GI bleed, don't present to me.
Your GI bleeder, the guy from the other day, he's okay. He's
Is he?
He's alive.
I thought for sure that guy was going to die.
No, he's extubated, he's good.
Oh my God, I'm totally shocked. Guy, we transfused him so fast.
Yeah.
Wow, really excited. That's a really good case.
It was just ulcers.
Just ulcers. Yeah, I told him they didn't have Varices. They didn't listen.
That counts as say.
See, we broke your streak. First one on.
That's a really good case. I'm really happy to hear that.
Yeah. You just needed to work with me. I broke your streak.
I appreciate it, man. I'm going to make you work with me every shift now.
I won't complain.
I need help. I need a guardian.
I'll